Assalamu alaikum. Today we are going to discuss two important topics that are relevant to anesthesia. One is the post-operative pain management and surgical ICU. You all know that after surgery, patient suffers from different kinds of pain and different intensities of pain. Pain is basically relevant to the surgery that actually has happened. It may be a very minor surgery and it may be a major surgery like laparotomies or thoracotomies. Different kinds of surgeries actually give originate to various kinds of pains that are relevant to the surgical incision. Before going into detail, the first topic about the post-operative pain management, let's see what pain is. So basically, if we talk about the word pain, then the etymology of pain. Etymology means actually it is the history of the words that have evolved from different languages. So in the Middle English, or that comes from the Anglo-French, it is basically derived from the word peni, that means pain or suffering. From the Latin word poena, that means penalty and punishment, and it also has been evolved from the Greek word poine, that means payment, penalty, or recompense. So basically, whatever the language is from which the word pain is evolved, the basic meaning remains the same, that there is suffering that or that has been caused by some triggering factors. And today we are going to discuss the triggering factor, that is surgery, because we are discussing the post-operative pain today. So the concept of the pain is very old, it's not new. And from the very ancient periods, the people, they are aware of this phenomena that is known as pain. In 1979, the International Association for the Study of Pain has given the definition of pain for the very first time, and according to them, the pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. It is, of course, pain is never pleasant. Any one of you has some or sometimes one or the other times they have experienced pain in their lives. It is, of course, sensory because it's a sensation, and there is also an emotional component. Some people feel anger, some people feel fear, some people they, actually weep, and this all actually related to the emotional component of the pain. So it has two components which are unpleasant for that person who is suffering from pain. And the second component of the definition suggests that there is either actual tissue damage or there is potential tissue damage. Actual tissue damage is one of the example is the surgery, in which somehow the tissue has been damaged due to surgery, or potential tissue damage. Sometimes there is no actual tissue damage, but there are chances that that tissue is going to be damaged as a result of inflammation or some other process. So whenever there is going to be some damage, it will produce some unpleasant sensory and emotional feelings, and that includes in the pain. But it was 40 years back. Now, this definition has been revised by the Task Force of International Association for the Study of Pain, and they say that pain is defined as unpleasant sensory and emotional experience which is associated with, or that resembling, that associated with actual or potential tissue damage. So it's not necessary that it is associated with the actual or potential tissue damage, but it may resembles that some tissue damage is going to take place or it has been taken place. So basically, it is always unpleasant, it is always sensory, there is always an emotional experience. It is associated with the actual or the potential tissue damage, or it may resembles that it is associated with the tissue damage. So there is going to be a revision of the definition of the pain nowadays. You all know that pain is always a personal experience, which is influenced by various degrees by biological, psychological, and social factors. Biological, there is a difference in the perception of pain among women and men. So there is gender, in gender they are different. If you see how the kids, they are children, they feel pain is quite different from that is observed or felt by the adults or by the old people. Psychological component is also very important. The psychological component is more prominent in the female gender rather than male. Male used to tolerate pain to a much more degree than the females. And there is also social factors are involved. In the lower socioeconomic status or families, the tolerance of pain is more than the people who are living in the high socioeconomic status. So there is always a difference in pain, and it is always influenced by so many factors. And whenever a person reports that he or she is feeling pain, it must be respected because pain is a thing which you cannot see, that can only be described by the person who is suffering. So you must respect how the person is expressing about his or her pain, because all the other vitals, pain is regarded as nowadays as a vital, like temperature, pulse, blood pressure, respiration. It is a vital sign, but this vital sign cannot be seen through the eyes. It can only be narrated by the person who is suffering from that pain. And pain, on the other hand, it produces various adverse effects on the functions of the body, on the social status of that person, and also on the it produces a very deep effect on the psychological well-being. The person who are suffering from chronic pains like osteoarthritis, or patient who are suffering from the pain that are relevant to cancer, because of this pain, their socioeconomic conditions, they are being damaged, and they are suffering from various psychological disorders like depression. So pain is very important phenomena that will affect, produce various adverse effects on the life of a person. But each and every person needs a variety or variation in the in requirements of the analgesics. It depends. If the person is coming from surgery, then it depends upon the site and type of surgery. Sometimes some surgeries, they took place only under local anesthesia, and that is sufficient. But in other surgeries like laparotomies or thoracotomies, or there's going to be a wide incision, and that is followed by sometimes a wide excision of the cavity contents. It depends what kind of surgery is going on and what is the site of that surgery. The all the major surgeries, they need a high analgesic requirement by the person who has undergone. It also depends upon the age of the person. As I told you that there is a big difference in the, as I told you, that there is a big difference among the pediatric population and the geriatric, or that is the old age people and the adult persons. So the requirement is different. Even in the male and female patients, in the female patients, the requirement of the analgesic is much more higher than the males, and also depends upon the body weight. The more fatty the person will be, there is going to be more requirement of the analgesics. Psychological factors, they are also very important because sometimes one or two analgesics, they are not sufficient to provide adequate relief to the patient. And again, there is pharmacokinetic and pharmacodynamic variability in all the persons who are undergoing surgery. It also depends upon the site of the operation, that what is going to be the duration or severity of the post-operative pain. If there is abdominal surgery, then the duration of the post-operative pain may extend up to 72 hours, especially in case of upper abdominal surgeries. In case of thoracotomies, this is much more. It is much more than 96 hours. So the duration of the pain is much more. The severity of the pain is much more. In case of facial-maxillary and limb surgeries, again, the ranges of the pain is up to 24 to 48 hours. So it basically depends upon the site of the surgery, what kind of surgery is going on. And we can monitor the severity of the pain through various scales which are available. They are known as the visual analog scale. There may be numerical space. In numerical scales, there are numbers are given 0 to 10, and the person is asked the intensity of the pain according to that, whether the person is having 10 number pain or 0 number or any from 0 ranging from 0 to 10. There is another scale that is known as the visual analog scale, and visual analog scale contains certain phases, and you can correlate the face that is present on that with the face of the patient. So by that you can decide, okay, what kind of the severity of the pain that is present in this patient. You can see from this slide that the most intense pain, if we go through this severity of pain scale, then it is through the thoracotomy, when the chest is opened for the lung surgery or for the cardiac surgeries, and it lasts much longer, up to 96 hours, and the severity of the pain is up to maximum, that is the scale 4. Then just talked about the psychological factors that can influence the post-operative analgesic requirements. It depends upon the personality also. In the extrovert people or in the neuroticism people, it is much more high. It also depends upon the social background. We just discussed that in the lower socioeconomic condition, the poor people, they tolerate pain much more easily rather than the people who are belong to high status. It also it depends upon certain cultures, that in certain cultures the expression of the pain is regarded as bad, so people used to hide that they are suffering from pain. There are also motivational factors. If like in the laboring ladies who are suffering from labor pain, if they are already motivated by the obstetrician, by the pain physician, and they know that how much intensity of the pain they will suffer from and at what stage they must ask for the labor analgesia, then this motivation actually works, and it will decrease the intensity of the pain that is felt by the person, and it also reduces the post-operative analgesic requirements. And another very important thing is the pre-operative psychotherapy. If you tell them, especially the laboring ladies, or that how these contractions will come, how they will suffer from pain, then this will be very helpful, and this psychotherapy will all decrease the intensity of the pain. So pain is associated with various signs and symptoms. It is not something that is actually felt at a typical site. It is associated with respiratory systems, it is associated with cardiovascular systems, and so many other things. The post-operative pain is associated with, most importantly, with the respiratory systems, and there is rapid and shallow breathing that will decrease the functional residual capacity, and that in turn, of course, will cause imbalance in the ventilation perfusion ratio, and resulting is the atelectasis, and this can cause decrease in the oxygen saturation of the patient. So person will hold breath, or person will not breathe properly because of that pain. This is most frequently seen in the patient who are undergoing upper abdominal surgeries and thoracic surgeries. If at this stage they will be provided with additional oxygen, they are provided with the adequate analgesics, then these problems, these complications, they can be reversed very easily without causing any further advancement. In patients who are susceptible to MI, or who are having already cardiac compromise, they can develop due to this postoperative pain, myocardial ischemia or infarction. This arrhythmias, whether tachy or bradyarrhythmias, they are also not uncommon in these patients. And in susceptible individuals, congestive heart failure can take place. And on the other very hand, because of the pain, patient will not move, and this immobilization of the patient will result in the hypercoagulability state, and there are increase more and more chances of developing of the deep vein thrombosis. That is also a very common complication after the major surgeries. Another very important problem that takes place because of this pain is the postoperative ileus. There is going to be a decrease or absence of the motility of the gut, and that will produce various other problems. How you will treat this pain? Again, there are two types. One is the pharmacological, that is mostly adopted all over the world. Another is the second one is the non-pharmacological. As the name suggests, in pharmacological you will use certain drugs, while in non-pharmacological you will use certain methods to treat this pain. In pharmacological, basically, we use various kinds of combinations of drugs. The most important drug is the opioids. You can use conventional methods of opioid administration, like you can give intramuscular or subcutaneous on-demand bolus whenever patients suffer from pain, and the bolus dose can be given. Another is you may give bolus or continuous intravenous infusion or patient control analgesia. So there is parenteral administration of opioid is very important. In the continuous intravenous infusion, the opioids are given into the infusion pumps, and they deliver continuously a very small dose to the patient. While in patient control analgesia, you need a specific device that is known as the PCA pump, in which syringe is already made up of certain concentration of the opioid is already made, and when the patient presses the button that is present on the device, then a prefix amount of the opioid is going to be delivered through the intravenous line. Then if again the patient presses the same button, it will not deliver any drug, because there is going to be a lock the period between the next dose. For example, if the patient is giving a drug or a dose at 10:30 a.m., then the doctor who has set that patient control analgesia pump to half-hour time interval, then if the patient, even the patient presses the button, the drug will not be delivered again. The second dose will not be delivered again till 11 a.m. So there is going to be the time interval, fixed time interval of half hour. This is actually done to prevent the adverse effects of the opioids in that patient. And the most common adverse side effect is the respiratory depression. Another way of giving opioids is through the spinal or the extradural route, and they are also very effective in certain kind of surgeries. Other non-parenteral administrative routes of opioids, they may be given sublingual, oral, transmucosal, rectal, transdermal, nasal, inhalation, or intra-articular opioids. So opioids, they are most commonly used drugs to treat the post-operative pain, and they can be given through the conventional intramuscular route. They can be given through the parenteral route, intravenous route. They may be given as bolus. They can be given as continuous infusion. They can be given as patient control analgesia. Other routes of giving opioids are the regional techniques like spinal, and even they can be used through the non-conventional routes, including rectal, nasal, and others. And we can use other drugs also, in which we can use local anesthetic techniques. Suppose the patient is undergoing nephrotomy or thoracotomy, we can use nerve block techniques. We can use local infiltration of the anesthetic agents. In the initial lectures, when we were discussing pharmacology of the local anesthetic agents, then I told you about this local anesthetic techniques, in which you will just infiltrate the area with the local anesthetic solution. Another is the Entonox, which is 50% nitrous and 50% oxygen, and it is mostly used to provide relief from the labor pain. NSAIDs, they are very popular drugs, and but the problem is that they are available. We can be anesthesia in anesthesia. We are supposed to use the drugs through the parenteral routes. The diclofenac sodium is available for the intramuscular and IV infusion type, uh, while only that can be given as IV injection. And said available is the ketorolac, and it is given frequently to the patients. It can be given in a dose of 30 to 60 milligram per day through the IV route, but it must be avoided in patients who are suffering from the coagulation disorders, or who are having uh, allergic or ulcerative problems, or also in the obstetric population. So ketorolac is not advised in the patient who are suffering from the coagulation bleeding disorders. While very famous is the paracetamol, that is acetaminophen, and it is available in the infusion form, and it can be used safely in all the patients. While another very rare drug, that is the NMDA antagonist. This is the receptors which are present in the spinal cord, and they are responsible. If the antagonists are used, they can block the pain. In the local anesthetic techniques, spinal nerve blocks, epidural blocks, or caudal block, that is the sacral epidural block, they are very commonly used. In the spinal nerve blocks, it lasts for only 3 to 4 hours, but the actual post-operative analgesia can be provided through the epidural, because it can be used as a continuous technique, and you can give drugs for a very long period of time, even 3 to 5 days. Caudal block is given only once, and it is a very important technique that is used for the pediatric patients. Other regional techniques they are most commonly used are the intercostal nerve blocks and the paravertebral blocks, brachial plexus analgesia, the combined ilioinguinal and iliohypogastric nerve block, that is mostly used for the herniorrhaphy, and also the local wound infiltration. These are regional techniques. They are very important to provide relief from the post-operative pain. The opioids, they are responsible for analgesia, sedation. They also suppress cough and cause vasodilation, but the problems associated with opioids, they cannot be neglected. They can release histamine, they can cause constipation, nausea, and vomiting. They are very common with the use of opioids. So you must give antiemetics first. And when we discussed in the lecture, that was the pre-operative assessment and pre-medication. In the pre-medication component, I told you about the use of antiemetics before the administration of anesthesia. Pupil reconstruction is caused by the opioids, while in the biliary colic they are usually avoided, and the other problems which are associated with the chronic use of opioids, they are tolerance and physical dependence. If we talk about non-pharmacological methods used to uh, relieve the patient from the postoperative pain, they are cryotherapy, in which the cold uh, uh, these are the cold therapies in which the instruments are used to relieve the pain. You are not supposed to learn these things in detail. Only these names, they are sufficient for you to learn. Another is the TENS. TENS is the machine in which through a very small current is passed into around that nerve, so that it can actually blocks the transmission of the pain. So TENS is very important. Acupuncture is a Chinese method in which there are certain points on the body which are responsible for the production of pain or transmission of pain to the brain. And these typical points which are you can, if you search on Google, you will see a picture where these triggers, these points are present, and the Chinese people, they used to insert certain needles and probe them into the body, and this will reduce the pain. Psychological methods, they are very important because from the very beginning we have just seen that the psychological condition of that person plays a very important role in the perception of pain. If we are going to block these psychological problems, and we can motivate that person, then the intensity of the pain can be reduced and pain can be managed very effectively. A very important terminology that is used by the anesthetist for the management of the postoperative pain is balanced multimodal analgesia. Now, how it is going to be defined, and or what are the components? It is very important. This question is very, this actually slide is very important from your exam point of view. You can be asked, what is balanced multimodal analgesia? So basically, it is an epidural infusion of a low dose local anesthetic and opioid mixture along with systemic NSAIDs. This will provide a complete analgesia to the patient. So this is known as the balanced multimodal analgesia. Along with the advantages are that it produces excellent pain relief. It avoids the need of for systemic opioids. You don't need IV opioids, and also speed up the recovery of GI function, and the chances of paralytic alias, which we just have discussed, are going to be at a minimal. So this was all about the post-surgical pain and its management. Now we will go through very quickly what a surgical intensive care unit is. I hope you have gone till the fourth year into the hospital, and some of you, they have visited surgical intensive care unit that is present in the hospital. If not, then when this corona crisis will become over, then you can visit that surgical intensive care unit. So what is a surgical intensive care unit? We will discuss in a while. These are the different pictures of my department. So the intensive care unit basically is the unit in a hospital where they seriously ill or critically ill patients, they are cared by specially trained staff. So it means it has two major components. One is the patients, they are not suffering from minor disease, they are not suffering from mild diseases, they are very critically ill or they are very seriously ill, and they are not cared by routine staff of the hospital. They are cared by very specially trained staff. And surgical intensive care, basically, it is a multi-specialty medical care center for critically ill patients who need care after the surgery. or who will undergo surgery after optimization, or who are recovering from the surgery. So it is basically SICU is concerned with the patient who will undergo surgery or who are recovering from the surgery and who are terminally ill. So basically, we receive a diverse group of patients in our surgical ICU. They are critically ill patients. They may be suffering from surgery. They come after transplant surgeries, thoracic or orthopedic patients. They coming from urology department or from the head and neck surgeries, or who are suffering from sepsis or there are any other problem like delayed recovery, or who need monitoring because somehow their systems or organs they are not functioning normally and their function is compromised. So a variety of patients are dealt at the surgical intensive care unit, their, for the treatment of their infection, for the support of their organs, and also ventilatory support, or if they are not maintaining their blood pressure, the hemodynamic support is given. Oh, let's see what is basically critical care. Critical care is kind of medical care for the patient whose illness requires close, constant watch by a team of specially trained caregivers. So this care is provided at intensive care unit. It can be provided critical care सबसे ज़्यादा कहाँ होती है? It could be provided either in the intensive care unit or it may be provided in the trauma center. But these patients are very ill and the treating people they are already trained in treating them, and they put a very close constant vigilance on those people. The population actually varies. It could be adult and pediatric. In PMCH we are having the adult surgical intensive care unit, though we deal with the pediatric surgical patients also. While there are various kinds of the surgeries that are going on within the hospital, from the orthopedic, general surgeries, facial-maxillary surgeries, thoracic, neurosurgical patients, and obstetric or gynecological patients, all patient populations, they can be admitted into the surgical intensive care unit after their surgery. What is the team that is included? They include physicians, nurses, respiratory therapists, pharmacists, physiotherapists, dietitians, medical radiation technologists, laboratory technologists, trauma coordinator if the person is coming due to some trauma, social workers, clinical educator, nurses, ward clerks, and pastoral care. Pastoral care is actually the clergyman or the Maulvi Sahab who is associated with that intensive care unit to offer some prayers and so on. Basically, it is a multidisciplinary teamwork. It's not a single person's work. It involves so many people who work together to bring about the health and care of that patient so that the patient can improve from the critical illness. What are the most important equipment that are needed at surgical ICU are mechanical ventilators, in which through which the breathing is provided to the patients who cannot breathe on their own. It can be provided through endotracheal intubation or through the tracheostomy tubes. Cardiac monitors are mandatory. Sometimes in some ICUs, the external pacemakers they are inserted if the person needs them. Or there is clear indication. Defibrillator is another mandatory requirement for the surgical intensive care units. Even must be present in the operation theaters. As we have gone through the cardiac arrest algorithms in which I told you the use of defibrillators. You can use automated external defibrillators or you can use the manual defibrillators. In the highly equipped surgical intensive care units, dialysis requirements must be present, dialysis equipment must be present to carry out dialysis in the patients who are suffering from renal dysfunctions. There must be equipments that do continuous monitoring of the bodily different bodily functions, including temperature, so on. Intravenous lines, feeding tubes, NG tubes, suction pumps, drains, catheters, and a wide array of drugs must be present to treat the patient who is suffering from multiple dysfunction, organ dysfunctions, or any other thing. ABG machine is very, very, very important instrument that must be available, because without ABG machine you cannot ventilate the patient on mechanical ventilators, and how to when to put the patient on ventilator, when to wean or remove the patient from ventilator, what modes of ventilators are required, how much oxygen to deliver, what respiratory rate is going to be set on the ventilator. They all are going to be decided on the ABG report, arterial blood gases report. It is arterial blood gases report, in which you will come to know about the pH of the blood, about the partial pressure of the carbon dioxide, partial pressure of the oxygen, and bicarbonate. In good machines, lactate is also being done, and this will give you an idea that what is the sepsis, whether the patient is in sepsis or not. The monitoring of the patient is conducted by the saturation, by looking for the saturation, for the blood pressure, for ECG monitoring is also very important. Blood pressure is again of two types. In some ICUs, invasive arterial lines, they are inserted, which are also helpful to withdraw the arterial blood gas sampling, while in the other, the non-invasive routine blood pressure monitoring is being done. Now, these are the various monitorings which must be done continuously in all the critical ill patients. They include heart rate, blood pressure, respiratory rate, pulse oximetry to see the saturation of the patient. And then hourly urine output is very important. That tells you, or gives you an idea about the urinary function of the patient. Body temperature is very important, because in certain cases you need to induce hypothermia in that patient. So maintaining a certain temperature is very important. Then the blood gases that we just discussed, that it is very essential to keep the patient on ventilator. Now, how you are going to organize an ICU? ICU is not the collection of certain beds or equipments. No, there is a proper organization of ICUs, and there are working principles of ICU staff. It must be located in a very close proximity to emergency room, operation theaters, trauma ward, diagnostic facilities, blood bank, or pharmacy. So its central location is very important, and everything should be very near to surgical intensive care unit. ये नहीं कि आपका surgical intensive care is 1 kilometer or 3 kilometers away from the main hospital building. And then there should be a single entry and exit, not more than that, so that you can maintain a harmonious way of entry and exit of the patients. And there must be another uh, entry and exit, that is for the supply of the drugs, equipments, and any other things, or for the public, or for the visitors who are coming to see that patient. So basically, for the patients, there must be one route through which the patient comes and exits, while for the people who are coming, or relatives who are visiting that patient, or for the movement of the instruments, equipments, and drugs, there must be another route. It is also recommended that the ICU strength, bed strength is kept between 8 to 12, not more than 6, or not more than 24 in any case, because it needs a very high logistics, very much it is much expensive, and it is very difficult to manage these patients. We at PMC are having a 12 bedded ICU, and there must be 150 to 200 square feet per open bed with 8 foot in between beds. So this is the actually area that is allocated per bed, and between the bed there must be space given. They must not be crowded in the ICU. Then intensive care is a very expensive healthcare services, while it will cost almost 2.5 times more than a normal bed in any present in any ward of the hospital. So why the patient are get admitted? There are so many cardiac causes you can see over here. But it could be emergency causes, they may be surgical causes, or they may be after post cardiac arrest. Then there are pulmonary and neurological causes. You can see that um, these are mixed causes. In surgical intensive care units, the patient not only enter or get admitted because of the surgical reasons, but they can be admitted because of the associated problems. Sometimes there is only acute respiratory failure, or there is pulmonary embolism or hemoptysis that need to that require their admission into the surgical intensive care unit. While the person who are suffering from the uh, strokes or intracranial hemorrhage, or there are coma because of various reasons, they can be admitted into the medical ICU or pay. Sometimes the known cases of epilepsy, they come in case status epilepticus, and they need to be put paralyzed to stop that continuous electrical activity of the brain going on, that is causing continuous convulsions and fits, and they are put down on the ventilators for the further management. And if the in persons who have suffered from brain death and their organs are going to be harvested for the transplantation, they need to be put on mechanical ventilation in surgical intensive care units. In traumatic patients who are suffering from head injury or polytrauma, they need also to be admitted in the surgical intensive care units. Again, in medical ICUs, other situation conditions like hepatic failures and severe pancreatitis or diabetic ketoacidosis, they need to be admitted in the intensive care units. But as in our hospital, there is only surgical intensive care unit is present, no medical ICU is there. So we receive all kind of patient in our ICU. Drug poisonings like OPP or Blackstone poisoning, they also get admitted into the surgical intensive care unit. While the post-operative patients sometimes they need hemodynamic monitoring, ventilator support, or extensive nursing care because of their prolonged surgery or surgery of major organ, they need they are sent to the surgical intensive care units. So, patients who are in shock or in respiratory failure or are suffering from the burn, near drowning, electrical or lightning injuries, suffer from hypo or hyperthermia, or there is new onset of anuria, or they are suffering from severe acidosis or alkalosis, they all are referred for the management in the intensive care unit. Now, once they are going to be admitted, then the primary team who will receive that patient will provide a report, will be provided a report on the patient prior to admission, which includes all the problems the patient is suffering from, why the patient is getting admitted in surgical ICU, and what are the further plan for the management of that patient. And when comes the time of discharge, then basically the status of the patient admitted to the ICU, it is revised continuously to identify the patients who do not require ICU care. And when a patient's physiological status is stabilized and the need for ICU monitoring care is no longer necessary, then it is going to be shifted to the ward. They're not discharged from the ICU. Basically, they are shifted from the ICU to their respective wards in which they are admitted, and from their wards they are going to be discharged. But sometimes the patient's physiological status has deteriorated and active intervention they are not longer planned, then they can be referred and they can be shifted from the ICU to their respective wards or to other hospitals for their further management. So this was all about the post-operative management strategies and the surgical intensive care. Hello. उसको पूछे ना फर्स्ट क्वेश्चन. बेटा अगर अब आपको कोई क्वेश्चन पूछना है तो आप पूछ सकते हो. कोई क्वेश्चन बेटा आप पूछना चाहो तो पूछ सकते हो. एनी क्वेश्चन प्लीज. हेलो, कैन यू हियर मी? बच्चे आपने कोई क्वेश्चन?
नो क्वेश्चन.
क्योंकि ये काफी हैक्टिक किस्म का टॉपिक है, लेकिन ये इसमें से इस स्लाइड्स में से कम से कम भी 2 MCQ या इस तरह की चीज आ सकती है. इसलिए ये प्रेजेंटेशन, आज की प्रेजेंटेशन बहुत इम्पोर्टेंट है. लॉन्ग क्वेश्चन नहीं आता लेकिन MCQ आ सकता है. तो इसीलिए अगर आपको कोई क्वेश्चन पूछना है तो आप पूछ सकते हो.
मैम ये जो लेक्चर है वो सेंड कर दीजिए.
जी बेटा, बात करें.
मैम
स्लाइड क्या?
मैम वो सेंड कर दे.
वो बेटा सेंड कर देंगे. मैंने IT डिपार्टमेंट में ही बैठी हुई हूँ, मैं इनको कह दूंगी ये स्लाइड सेंड कर देंगे, लेकिन आपने इन स्लाइड्स को अच्छी तरह देखना है. इसमें से कम भी आपको 2 MCQ मिलेंगे. ओके, ठीक है.
ओके मैम, थैंक यू मैम.
ओके बेटा, थैंक यू.